Dr. Rosenthal has another commitment, so he has to go first, and I'll start and introduce him. He's going to talk about gastric sleeve, a single-center experience, and Dr. Rosenthal.
Thank you, Dr. Richards, and thank you, Dr. Farr, for the opportunity. We're probably now over 1,500. When we submitted this for consideration, we were with over 1,000 of these sleeve gastrectomies. And I think this is important to show a single-center experience because most of what you see is a multi-center experience where morbidity and outcomes are become a little bit unclear. So these are my disclosures. Sleeve gastrectomy is nowadays the most popular procedure in the United States of America. If you log into the ASMBS website, you'll see the numbers for 2011, 12, 13, and 14 has passed the gastric bypass, and those trends can be seen worldwide. I just came from the Asian Pacific region from their meeting, and in all countries across the Asian Pacific region, sleeve gastrectomy is the most popular procedure. Michigan Collaborative just gave us their numbers for 2014. 70% of their procedures are sleeve gastrectomies. The outcomes in the short term are excellent, but there are no long-term results. Some of the long-term results are small serious. And there is probably a lack of standardization. A lot has to do with the single incision and the robotic approaches and the laparoscopic approaches that have affected a little bit our outcomes. So the aim of our study was to look at 1,020 consecutive sleeves with a standardized technique. The endpoints were safety and what were the long-term outcomes when it comes to percent of excess weight loss, resolution of obesity-related comorbidities, complications, and the need for reoperations. Because this is the other big question. Well, I know that 40% of your sleeves will have to be converted because they fail. We did an institutional review, board approval, study, following HIPAA guidelines, retrospective review, a prospective collected database. We are in the MBSA QUIP. We've been in all databases you can imagine, and we've been with ACS since its inception. This is between January 2005 and February 2014. All sleeve gastrectomies were analyzed that were used as a sole procedure. The data we collected was height, body mass index, comorbid conditions, complications, perioperatively, hospital stay, early readmissions, early and late postoperative complications, and excess body weight loss. From 1,040 sleeve gastrectomies, we included 1,020. 66% of those were females with a mean age of 38 years. Most common comorbidities, you can see hypertension in 80% of the cases, diabetes in 89%, sleep apnea in 86%, and hyperlipidemia in 70% of the cases. And if you look at the improvement after the operation was performed, 91% improvement on the hypertension, 57% on diabetes, sleep apnea 99%, and hyperlipidemia 80%. If you look at the mean excess weight loss, we tell patients that all bariatric procedures work for the first 12 months, and that's true. And you can see that in the first year, we had 86% excess weight loss with sleeve gastrectomy, but as time started passing, and we're looking here at 8 years follow-up, the excess weight loss crippled down to 52%. Still, this is what we consider a successful bariatric procedure when you have excess weight loss more than 50% at 2 years, and we're talking here about 8 years follow-up. But don't be too happy, brace for impact. I'm going to tell you the truth. Mean hospital length of stay, 3.4 days. We are now probably by 2 days. We're sending patients home the morning of day number 2. Overall rate of early readmissions, 3.8%. That's below 4%, which I think is very good within national standards. The early less than 30 days complications, vomiting, 23% of the cases, dehydration, 19%. Prolonged ileus, 18, bleeding from a staple line, and that being diagnosed by blood coming out of the drain. So it was either the short gastric or the staple line. We had only one leak, and that was at the beginning of our series. Case number 7 was treated with relaparoscopy, drainage, and TPN, and our stricture rate of 0.1%. In the long term, more than 30 days, the stricture rate went up to 0.49%, 5 cases. Reflux, this is important because it's a big consideration. Should we be doing sleeve gastrectomies in patients with reflux? 6%. Overall conversion rates to a gastric bypass, 12 cases, 1.2.5%. Due to failure, non-responders, you can call them the way you want, weight regain, only 4 cases, 0.4%. Due to reflux, 0.5%. And due to gastric outlet obstruction, 0.3%. And this, I think, is the most, I would say, negative message that I'm giving you, and that is that in America, it's very difficult to follow our patients. You see that at 3 years, 81% were lost to follow-up, at 5 years, 87%, and at 8 years, 92% of those patients were gone. What are the reasons for that? Well, either because they move, they lose their jobs, they lose the insurance, they come from overseas, or because they're doing well, or because they're doing poorly. We don't know. But the truth of the matter, one of the difficulties we're having in getting our bariatric procedures approved nationwide is that the insurance says, well, I want to see your long-term follow-up. And this is the truth that most series that you're going to see at the long term have a poor follow-up. So in conclusions from our series, considering what I just showed you, we can say that sleeve gastrectomy is safe, if not the safest procedure we have. It is effective, has high success rates, improves of obesity-related comorbidities, low rates of early and long-term complications, and obviously we need studies with higher numbers of patients being followed. I don't think we need more than 1,000 cases that prove that something is right or wrong, but certainly we need better follow-up. Thank you very much.
Thank you. This paper is now open for discussion, but let me start out the discussion by asking a couple questions. Number one, you really had 89% of your patients started out with type 2 diabetes. That's one of the highest rates that I've ever heard of.
Yeah.
That's just incredible.
Well, 70%, 75% is what you see usually.
Huh. And these strictures that you're seeing long term, where are the strictures, and how did those patients present?
Well, usually these patients present with heartburn, epigastric pain. Some of them have back pain, signs of reflux, nausea, and vomiting, you name it. And usually it's also error in technique, errors in judgment while you get strictures.
Dr. Wren.
Unusual? And you think unusual?
I've not seen any strictures after a sleeve gastrectomy, unless you want to call narrowing at the, incisura, quote-unquote stricture, but that usually presents very early rather than a peptic stricture as, I think of a peptic stricture or the strictures that you see after gastric bypass from a marginal ulcer.
Well, remember that late are more than 30 days. Early is less than 30 days, late is more than 30 days. So
right.
Month and a half. I mean, it's very common to have these patients having nausea and vomiting, so it wouldn't be unusual to find a stricture in the long term after 30 days. Yeah.
Christine Wren, NYU.
Hey, Christine.
Congratulations.
Thank you.
Thank you for presenting such nice data. Now I understand how people might have felt when I was presenting my band data, because it's very good. And we've had some other issues that I wanted to ask you if you've seen. Have you had any portal vein thromboses or SMV thromboses? Because we've been struggling with some of that.
Yes, we did. We had 2 cases. Usually we see them with patients that have complications. In the long term, we've seen them that came for other reasons. You can call them dehydration, but either they develop acute cholecystitis, and suddenly we see them and say, well, they have portal vein thrombosis. It was difficult to blame the sleeve for that. It was in the long term, but we did see that. And as you well know, there have been series published in obesity surgery coming from South America, specifically from Chile, with very large series of patients with portal vein thrombosis. So a difficult subject.
You did not include them in the
because they were not related to the operation, in my opinion. We've seen them in patients that underwent sleeve gastrectomy, but it was in the very long term, and they came with other kind of complications, with other kind of acute abdomens that I couldn't blame for the sleeve.
So you saw them farther than 30 days?
Correct.
I see, because we've always had them within 30 days.
Correct.
Okay.
But again, we've seen them, we heard them, and you read them, so this is a valid consideration. Thank you.
Go ahead. Please state your name and where you're from and ask your question.
Yeah, Muhammad Abdulain, United Kingdom. In the area of using the bypass as a treatment of diabetes, are we still offering sleeve for diabetic patients, or shall we offer them a bypass from the start, because you have a lot of diabetic patients in your study?
Yeah. You see, if you look at the STAMPEDE trial, that I believe is the best level 1 evidence trial looking at gastric bypass, medical treatment, and sleeve gastrectomy for diabetes, the conclusions of the paper, at least, that's what it reads. It says that you can offer them bypass or sleeve. So I personally don't make a difference. Diabetes is not the reason why I offer a patient a bypass or a sleeve.
Okay, thank you very much.
Well, I'm not sure that I would agree with you that the STAMPEDE trial said that. Actually, the long-term results suggest that the gastric bypass is much better for the treatment of diabetes in that trial.
The conclusions read, for patients with diabetes, you can offer them both.
Well, you can, but you're making the point, you're almost saying they're equivalent procedures. They're not. The gastric bypass is clearly superior to the sleeve in the STAMPEDE trial.
Well, I have to disagree with you because I know that trial very good since it comes from our clinic. It tells you that the weight loss is better with a bypass, but the remission of diabetes is not statistically different at 3 years when you compare bypass versus sleeve.
Okay. Yes.
I am from Ecuador.
Yeah.
Can you tell us, please, your standard technique in this study?
Well, we published it. We did a consensus meeting. Was published in SWORD. It's pretty much using a 38-French bougie, taking down the short gastrics. We tried to stay away from the 3 corners, incisura angularis, gastrosplenic, and angle of His, corner of the stricture, the bleeding and the leak. That's how we call them. And it's a 38-French bougie. There are a lot of little nuisances. I don't think we have the time to go over the technique now.
No, I think we just need to wrap up this session.
Thank you very much for the opportunity. The questions under discussion, Bill.
Excellent. Thank you, Dr. Rosenthal.